Dr. Yewande Adeshina joins us again today to shed some light on the goings-on, how we are handling the Ebola case in Lagos. I say we are not in Lagos State Health Sector, I know. Thank you for coming on this morning.
Thank you for inviting me.
Yeah, we're looking at this headline now. We'll have to start from there. What is this about? Another suspected primary patient dies in Louth?
What we're seeing is a resurgence of the initial panic with what happened with Mr. Sawyer. People are feeding on the frenzy of the numbers that are going up, of the different stories that are out there. We've had people die, and the first differential diagnosis is Ebola. And we're having, it's actually becoming very burdensome because the minute you hear Ebola, we have to act as if it's Ebola. Because not knowing, when the provider doesn't give us enough information of how they came about the diagnosis, we have to get kitted and the body has to be processed as if it's Ebola. And we've done 4 bodies now and they're all negative. And I really want to seize this opportunity to appeal to our healthcare providers that we have given them trainings, we have given them standard operating procedures, we've given them all the information they need to be able to triage Ebola appropriately and make a differential diagnosis and not refer patients to the Ebola treatment center. You need to keep the patient in your facility, call the Ebola helpline. The rapid response team will come, assess the patient on a deeper, more comprehensive level. And if they think it's Ebola, we will evacuate and decontaminate your facility. If we don't think it is, we will make our recommendations and the patient's life goes on. But we're getting a lot of this panic thing coming back again. Doctors refusing to see patients. Doctors referring patients to the treatment center, doctors not being proactive in treating patients, so when they die, they don't have enough information to confirm the cause of death, and automatically they call it Ebola. So our centers become a lot more burdened with all of these, well, they're unnecessary, but because we cannot leave any stone unturned, we've had to address every case as if it was. And a lot of resources have gone into it. But so far, there's no need to panic.
Why do you think, sorry, Chamberlain, why do you think that's the case? Because if a doctor is afraid, is it a case of inadequate PPEs or some kind of facilities to treat such?
No, it's not. You don't need PPEs to diagnose Ebola. You don't. If we get our standard precaution in place, it's by direct contact. So I'm a doctor, a patient comes into my clinic. If my reception is well trained on infection precaution system, they will know how to get information from that patient without even having physical contact with the patient. The patient, we have designed a triaging method where fever and recent travels are to be asked at the very onset. So this may be a situation for separating this patient. You don't sit that patient in the general common waiting area. We've asked all of our healthcare providers to create a separate room where if they suspect anyone has Ebola or is coming on with features that may be similar to Ebola, put them in that room.
Because it looks as though all of them put every new patient in the general room.
That is the system. That is the style. In an ideal situation, if I had a clinic, I would have my sick separated from my well. That is the ideal, the ones for immunization. That is why with the primary healthcare system, we're doing the revitalization program. You will not find the children sitting with the adults any longer because they need to be separated. And we've established that model in our flagship PHCs. The patients for communicable diseases are not sitting with patients for non-communicable diseases. And that is the way the system's supposed to be. So if you have a patient that way, you keep that patient in a room. There are 2 advantages to that. You can streamline and get the rapid response to that room, and the decontamination will be less. Because if the patient happens to be a suspect, we have to decontaminate your facility. And the time we take to decontaminate is much less. If we have a specific place where we're going, from the way the patient comes in, the reception, into that room, and you're done. Some practices that have followed that instruction have been able to reopen in 4 hours the next day. But if you let the patient loose in your facility and so many people are coming into contact, it takes days to decontaminate, not knowing where that patient has been or who's been with the patient. So the issue is not of no PPE. Wear your gloves, wear your white coat when you need to touch the patient. Ebola is transmitted by touch, not by breathing, you don't have to be gowned up, kitted up to treat, to diagnose Ebola. In the treatment center, they gown up because this is where they stay, this is where they live. So they touch the table, touch the chair, touch remote control, gone to the toilet. So you need to protect everything. You can have aerosolized material, they can vomit and it can splatter on someone's skin. So all of those are the reasons why you take that precaution. I think that the reason why some doctors, not all, because we've had a few good responses, I have to say. The reason why some doctors are taking that approach is because of fear. They are afraid. You have to remember, doctors are human beings too, and they have emotions. And some of us are braver than others. Some will not even want to touch. Hence the reason why we have a shortage in our volunteer at the initial stage. People were scared. We all know pathophysiology of Ebola as doctors. We know how many species and all of that. We know the incubation period and all of that. But when it comes to going into the ward and taking care of the patients, they don't want to do that.
You know what comes to mind? I remember the first time you were here, you told us about how we can contract that virus. The person has to be physically sick.
Yes.
I'm trying to bring back the Port Harcourt scenario into play. A diplomat bolting away from Lagos. He wasn't physically sick at that time, I'm sure. And that's my own assessment.
Yeah.
Then get to Port Harcourt, and finally we have a case in our hands. Are you sure that the person must be physically sick before he can pass on the virus?
We are very certain about that. And I'll tell you why you cannot hold on to what you believe as the gospel truth. Because we've found that people have lied. People have been deceptive. Again, I believe it's out of fear. Because we have different ways of dealing with anxiety. We can go into denial. We can become introverted, just don't want to talk to anybody. You know what's going on, but you keep it to yourself. Or you just plain blank say, I don't have it. It's not my portion. I rebuke it. And if you rebuke it long and hard enough, it's not going to come. We found out that, and that's why we started bringing some people in for quarantine. We weren't doing that. There is a model that has been established with Ebola contact tracing, and it's called home monitoring. Because they are not contagious until they get sick. So we keep them at home and monitor. We have people that go out to them and check on them every time. And that's how we found out that the Port Harcourt index case bolted. Because day 3 on our contact list was when he was lost to care. He switched off his phone, he wasn't at home, we couldn't find him. And we got the SSS involved and tracked him to Port Harcourt. And by the time we found him, he was heading back to Lagos. So he was another case that, for whatever reason, and I can't give an answer to that right now, he maybe went to look for cure. He thought maybe there was better service. For whatever reason, he was looking for something. He, we believe, had been symptomatic. But even us at the time, some people will give you wrong temperature readings when they come. Some people, just because they don't want you to say, come in and get care, or because the minute the fever kicks in, you become a suspect, and we have to bring you in and test you. Some people are so scared of that stage that we found out that they weren't taking their temperatures well, or they were not giving us good temperature readings. So we have now
So
mandated.
that's when you call them,
Yes.
not when they come in.
Yes, at the initial
Okay.
stage, the first week when we were still trying to find our footings and trying to get the situation settled, because this is urban outbreak, which is never happened before. A lot of the outbreaks have been rural. So the urban outbreak required rearranging a lot of things to meet our needs as an urban system. So we were doing the calling, what's your temperature? When we found out that a few were kind of misleading, we had people in the local government physically go to their houses and check the temperature themselves. And this has actually worked out better. It meant a whole lot more people involved at the community level, but we're now at peace. And I think that is how we've been able to silence or quieten the Lagos outbreak, because we've not seen any new Lagos infection. We've not seen any new Lagos suspect. If this man hadn't gone to Port Harcourt and had stayed back and we treated him, we would have been singing bye-bye to Ebola by now, because we just have not had any. All the cases we're dealing with now are cases from Port Harcourt.